Good afternoon, ladies and gentlemen. I would like to thank the program committee inviting me to present this lecture about the differentiation between the cause of colitis. Just to let you know that I moved from Montpellier now to McGill University, where I work now. The learning objective of this presented lecture was to learn the most common cause of colitis through cross-sectional imaging in both immune-competent and immune-compromised patients. To become familiar with differentiating infectious, inflammatory, ischemic, and autoimmune conditions based on cross-sectional imaging criteria. But also to understand that cross-sectional imaging have some limitation, and we cannot always say this is this type of colitis. Most of the case we can say just there is colitis, and the diagnosis will be done by optical colonoscopy and blood tests and tool cells. Very quickly, I will go further to see the outline of the presentation. Very quickly about the normal colon, because it's also already been demonstrated very well by Dr. Smith. The positive diagnosis of colitis, when we can speak about this is a colitis. The disease spectrum is going to be like a catalog, and I will describe the different type of colitis, and more important, the criteria that can orient it to one diagnosis to another when we have some features. IBD, infectious vascular disease, and the diagnostic strategies that we can afford to manage this kind of patient. The normal colon. This is an high-resolution ultrasound image of the colon, and this is the only modality currently that gives you this resolution in order to see all the layers. Of course, on CT, we cannot see these layers. Here you can very well see the lumen, the mucosa, and the submucosa, and even here you can see the muscularis layers with the circumferential layers and the tinea longitudinata that are very well identified. This is, of course, in an ideal patient with high resolution, but this is not rare. And when you don't have obese patient, I will recommend all of you that if you practice ultrasound to try and to see that it's not so difficult to see and to evaluate the colon wall. On CT, like when the colon is distended, the lumen should be less than 2 to 4. And be careful, like Dr. Schmidt said, when the colon is not distended, especially in the sigmoid and the left colon, it can be up to 6, 7 without pathology. And we are radiologists, very commonly, we underestimate the diagnosis of colitis. And a lot of patients have nothing, and they just appears with a thick wall of the colon. Here is the VCT, and you almost cannot see the wall, which is less than 1 millimeter. I think the ideal techniques to see the wall, if you really want to analyze the layers on CTs, which is a barium enema, or a CT barium water enema, sorry. And this is a non-prepared that most of the time we cannot do any kind of preparation, and we do just a plain CT with intravenous contrast, of course, but without specific colon preparation, and that's what we do in emergency in 90% of the case. The positive diagnosis of colitis is based on the wall thickening, and the wall thickening in a distended colon of more than 4, and in a non-distended 6, 7, 8, especially on the left and the sigmoid, I said that be careful on the sigmoid colon, it could be very thick. Is the basic of this diagnostic. Here you can see the thickening with different layers, a layers differentiation abnormality, but the pericolonic fat abnormality is almost as important as the thickness of the wall. You can see these 3 different patients with 3 Crohn's disease pathology, one in CT, one in ultrasound, and one in MR. You can see the thickness and the differentiating and the target sign here, thick abnormality and fat stranding, and again in ultrasound and in MRI, that's almost the same image. There are numerous features that are associated with colitis. The most common is ascites. Ascites is very common in a lot of severe infectious colitis. You can find ascites, sometimes very moderate or subtle, sometimes more important. Here is a case of pseudomembranous colitis, and it's very known that ascites is associated with pseudomembranous colitis. But here's another case of colitis, polyarteritis nodosa, very severe colitis with a lot of ascites, and that's a reaction of the peritoneal layers. Another associated feature that you have to look for and that can orient the diagnostic is the lymph node. Here are two cases, a typical lymph node. Here, an inflammatory enlarged lymph node that you can find in Crohn's disease, for example, very large and enhanced lymph node. And here it's a case of very typical hypodense necrotizing lymph node in a tuberculosis. Also, it's quite important to analyze a small bowel to see if there is some abnormality associated with the colitis. And the diagnostic of an isolated left colon colitis and a right colitis with ileitis associated is very different, and the diagnostic are very different. When you have a lot of ileal involvement, most of the time it's infectious disease. Here it's a case of right colitis, with almost all the small bowels that involved, and that we saw very commonly during winter, during virus ileocolitis, and a lot of patients, if you do ultrasound, in patients that have abdominal pain and diarrhea, as you can find this kind of image. Other organ involvement, the patient after cardiac surgery that has right transverse colon colitis, very severe from ischemic origin. You can see some area of necrosis, and you can see that there is embolic on the right kidney, and of course that make easily the diagnosis. Let's go now to the complications that you have to look for in patients that have colitis or known for colitis. The most common complication is occlusion or toxic megacolon. And here it's a patient with ulcerative colitis with some kind of dilatation, but not toxic megacolon. And you have to be worried about this kind of patient with an area of left colon inflammatory change, especially in ulcerative colitis, and the beginning of distension of the right, because these are the patients that will go for and will risk necrosis and toxic megacolon. On this image, you can see a patient with a necrotizing right ventricle area due to a ischemic change upstream to a left colon cancer, which is clearly identified on this area with a pneumatosis. Other complication that you have to look for is peritonitis, which is quite rare, but we can see that in severe and advanced Crohn's disease, with here some free air in the peritoneum, or most common, abscess in the peritoneum, especially on the right ileocecal valve, around the right ileocecal junction. Let's go now to the description and the different disease that we can find. Very quickly, are we able to differentiate Crohn's disease from ulcerative colitis? Generally, we are not asked to do that because the diagnostic is not. It is not always the case, and that we have a lot of non-characterized colitis. And I'm going to show you some kind of possibility to try to differentiate the two entities. Just to remind you that the Crohn's disease at the beginning, you have just superficial after ulcer, but right after the ulcer are gaining deep and and are separated by normal mucosa. In the ulcerative colitis, in the contrary, in the other end, the ulcer are always superficial, and generally there is no skip area between the ulcers and the involved area. Let's go now to the localization. The Crohn's disease is rarely colon only. Sometimes sigmoid colon only in 1/4, 25% of the case. Most of the case, when there is a colonic involvement, there is also some other involvement in the small bowel that can allow the diagnosis. In the ulcerative colitis, of course, we know that the rectum and the sigmoid colon are the most commonly involved, and according to the inflammatory of the disease, and there is more or less involvement of the diff and of the overall colon. If we look now to the pathology, and that we can try to see that on imaging, especially on MRI and on ultrasound, we can see that the Crohn's disease is a discontinuous abnormality with asymmetric, eccentric involvement, and all layers are involved in the thickening of the wall. In contrary, the rectal colic, the ulcerative colitis, is a continuous disease with symmetric involvement, and the involvement in the thickening of the wall involves the mucosa and the submucosa. And that's the echo pathology, ultrasonic pathology correlation between in the Crohn's disease and ulcerative colitis. You can see the muscularis that is thick and irregular, and you can see that also very well in ultrasound, and the irregularity of the hypodense mucosa and submucosa. In the ulcerative colitis, the muscularis layers is very irregular and is not involved generally, and the disease involves mainly the mucosa and the submucosa. Again, that's a Crohn's disease with an involvement of the whole wall, narrow lumen, fibrofatty colonic inflammation. Here an example of a Crohn's disease with a clear wall, irregular thickening in both in CT, in ultrasound, with fibrofatty inflammation and fast stranding. The COM sign is a very known sign for Crohn's disease. What is the COM sign? The COM sign is just inflammation of the vasa recta, you can see on CT, or here on ultrasound, that go through the muscularis layers and associated with a fibrofatty inflammation that gives like strings that are attached to the colon. Other abnormalities that you can find almost only in Crohn's disease are the presence of deep mucosal ulceration, like you can see here, that's this hypoechogenic area on ultrasound or hyper T2 area on MRI. Fistula, of course, when you see a fistula, and if it's not diverticulitis, it's generally a Crohn's disease. And most of the time, again, if it's not diverticulitis, when you have a big abscess and you have a colitis, it's mostly Crohn's disease. Stenosis located only on the colon is rare, but you can find that sometimes. What about ulcerative colitis? Ulcerative, like the same image I show on ultrasound, mainly involve the submucosa and the mucosa, and not the muscularis layers. In the advanced form, you can have this kind of pseudopolyp with abnormality of this pseudopolyp are due to the normal area of the wall in between the superficial ulcers. And again, which is very known but not so common to see, the rectal allophyne, that is the presence of fat in the submucosa, the rectal, associated with fibrofatty perirectal inflammation, which is a very classical feature of ulcerative colitis. Again, when you see a toxic megacolon, and in this case, that is most commonly related to ulcerative colitis. What about infectious disease now? Submembranous colitis is the most common that we see, especially in hospitalized patients. This is due to costly C. diff and the complicated antibiotic therapy, and this is really a life-threatening condition, especially in patients with ICU. In ICU, that you have to follow, and that is something that you have to describe to the intensive physician. What do we see in different imaging modality is a very thick wall colon, more than 10, 12, 14 millimeters, that involve also, again, only the mucosa and the submucosa. The muscularis layers are generally respected. This is the membranous that you can see in optical colonoscopy. But the importance of the wall thickening in a patient that is hospitalized or has been treated by antibiotics should be the more important features. Here again, this is this case with a severe pseudomembranous colitis that lead to colon resection due to complication. And you can see the importance, and that's with this correlation with a lot of ascites, some kind of accordion sign. The accordion sign is not very either specific or sensitive, but you can see it in pseudomembranous colitis, you can see it in other severe infectious colitis, or sometimes even in ischemic colitis when there are some reperfusion challenges. Other ileocolitis can range from pancolitis to localized right with ileocolitis. The more the involvement, more there is a pancolitis with ileitis associated. Generally, it's common bacteria or virus. When it's localized to the right side, and that the symptom can mimic appendicitis, you have to think about specific pathogen like salmonellas or Yersinia, and to involve the physician in charge of the patient and to inform him about this possibility. Here, the case of right but also left pancolitis. In this patient, it was due to salmonellosis. Here, it's another infectious disease which is more rare, but you can encounter it sometime. It's due to tuberculosis, and it's more generally localized on the ileocecal area with a big mass, very eccentric, asymmetric wall thickening, and associated, like we saw previously, with enlarged lymph node that are most of the time hypoattenuating or rarely calcified. And this is, of course, encountered in immunocompromised, but also in patients that just spend time in area of where the disease is present. Here's a case we saw with a 31-year-old man that is coughing, weight loss, right recurrent pain, and we did an ultrasound right at the beginning with all this enlarged lymph node, very thick colon right side with ileocecal involvement. This is a CT that shows also almost the same thing, but this very hypodense lymph node, and the chest CT that is easily the diagnosis. Typhlitis or neutropenic colitis is encountered only in immune-compromised patients, and the most common patients are the patients that have hemopathy that are treated by chemotherapy. This is right. Generally, most of the time, it's right colitis, cecum involvement, right colon involvement. Rarely, the ileal, the last centimeter of the ileal can be involved too. And this is a severe disease also, with some kind of inflammatory change and could lead to necrosis of the right colon. And again, this kind of patient should be really treated very in emergency. What about ischemic colitis? Ischemic colitis is very common currently, especially in elderly patients. And most of the time is a non-specific clinical symptom, patient with pain, some kind of diarrhea or bloody diarrhea. And most of the time there is no vessel obstruction. It's just post hypotension or any kind of vascular change, but there is generally no obstruction of the inferior mesenteric artery or superior mesenteric artery. The area of the location, the most common location, are the two sensitive areas that are the left colic flexure, junction between the superior mesenteric and inferior mesenteric artery, and the area of the rectosigmoid junction, which is the junction between the inferior mesenteric artery and the hypogastric branches. The left colon is involved most of the time in elderly patients, and is due to hypoperfusion. The right colon is less involved, but it's generally more severe disease, more in young patient, post-trauma patient, embolic cases. The rectal involvement is very rare. Here it's a case with the patient with 70-year-old woman, diarrhea with bloody stools, abdominal, non-specific abdominal pain, and she's sent to ultrasound for an abdominal ultrasound. And we found this hypoechoic, without Doppler signal, without layers identified, which is very typical of chronic ischemic disease. We did the CT, and that was the reperfusion phase, because the enhancement of the colon was there were more inflammation than ischemic change. And that's the difficulty with this kind of ischemic colitis. The hypovascularity of the wall is only seen as the acute phase or when it's very severe cases. But in a lot of cases, there is some post-ischemic inflammatory change that you can see on CT after injection. Another case which is very different is 2 days post-surgery and colon anastomosis. And you can see this abnormality of the left descending colon. And at the area of the surgical clip, you can see pneumatosis, and that's post-surgical ischemic change, which is common, and the patient needs to be reoperated to remove this area that is completely ischemic. What are the diagnostic strategy? If the colitis is clinically suspected, we are looking more for the diagnostic of severity, extent, and complication. Like I said, occlusion, toxic megacolon, ischemic infarction, parietal hemorrhage, portal gas, parietal pneumatosis, peritonitis, abscess, or to try to find an etiology or an origin of this disease. In emergency, the CT is probably the best test, very reproducible, very stable test. In case of IBD, of patient with known IBD, we really want to rule out repeated ionizing radiation, and I think MRI is now the tool, the test that we have to promote. Colonoscopy and biopsy are really guided for the positive diagnostic. But probably most commonly, we see patients without diagnostic, non-specific. What we have to do in patients we have with non-specific abdominal pain, for doing the positive diagnosis of colitis, to find the wall thickening, periconic fat stranding, parietal abnormality, we can do both ultrasound and CT, depend of the expertise and depend of the training of the team. CT is really recommended in emergency and in obese patients because it's really reproducible. In thin patients, in children, in young women, really ultrasound is a very good test. And I think most of the radiologists should be able to perform this kind of ultrasound. Colonoscopy and biopsy are sometimes mandatory to confirm the diagnosis. In conclusion, cross-sectional imaging of features and patterns are helpful to make the diagnosis of colitis and to rule out complication. When complications are suspected, CT should be the first-line imaging method. While imaging feature can help narrow the differential diagnosis or suggest a specific diagnosis, the final diagnosis is often based on clinical and laboratory data and colonoscopic and biopsy finding. Thank you for your attention.